Hello, I'm Jane Barnsteiner, and today we're going to be going through the Institute of Medicine and the QSEN Safety Competency Theory Burst. What is a theory burst, you're probably thinking? Well, a theory burst is a 20,000-foot view of the topic. It's essentially a brief overview of the elements of a topic to really set the stage for either a group discussion or for further study on the topic, in this case, the patient safety competency. The first thing that we want to talk about is what is the definition of safety. Previously, the definition focused on an individual healthcare practitioner's performance, their vigilance individually to keep patients safe. The contemporary definition of safety is to minimize the risk of harm to patients and providers through both system effectiveness and individual performance. By the end of this module, the expectation is that you will be able to describe what the processes are that are used in understanding the causes of error and allocation of responsibility and accountability. To be able to describe the factors that go into creating a culture of safety and the potential and actual impact of national and actually international patient safety resources, initiatives, and regulations. And then lastly, to help you identify opportunities to improve patient safety that will minimize human factors. The most essential message in this theory burst is to understand that safe, effective delivery of patient care requires every healthcare professional to understand the complexity of care delivery, what the limits of human factors are, what are some of the safety design principles, the characteristics of high reliability organizations, and patient safety resources. There are 20 knowledge, skills, and attitudes that are related to the safety competency. For more information on this, refer to the Cronenwet article from 2007 and the Sherwood and Barnsteiner book on the safety competencies that was published in 2012. The latest data on patient safety, which was published by Rogers in 2014, has upped the numbers to 440,000 deaths that occur in the United States alone due to healthcare errors. This breaks down to also 2,000 patients per day pick up an infection during a hospital stay, and 1,100 patients per day suffer from a drug error. In February of 2015, Consumer Report published a national survey in which they found that 29% of the people who participated in this survey said that errors had occurred during their or a family member's hospital stay. So we have a huge issue related to patient safety. And errors can occur anywhere along the continuum of healthcare. We have medication errors. As I mentioned, 1,100 drug errors per day occur across the United States. We still continue to have about 40 wrong site surgeries that take place each week in the United States, according to the information that the Joint Commission has. We also have diagnostic inaccuracy, which results in wrong treatments. We continue to have major equipment failures, transfusion errors, incorrect labeling of specimens that leads to laboratory errors. We have system failures, such as insufficient staffing or people working shifts that are too long. And we have environmental issues. Now, the contemporary approach to patient safety is to identify what are the core domains, what are the areas that we need to be conscious of. And there have been 6 domains that have been where the patient safety information is organized. And I'm now going to continue the rest of this theory burst organizing content around these 6 domains of culture, leadership, risk identification and analysis, data management and system design, mitigating risk through system thinking and design and human factors, and then the external influences on patient safety. So the first domain is the culture of safety. And what it's important to really understand is that safety is a property of the healthcare system itself. An organizational culture of safety acknowledges that all of healthcare takes place in very complex systems and human factors within the healthcare delivery system in general and within nursing practice specifically. There are numerous organizational safety culture assessment tools that are available, and it's recommended that every healthcare center do a culture of safety assessment every 12 to 24 months, where this is an assessment where all employees can participate. One example is the link here on this slide to the AHRQ Patient Safety Culture Assessment. So what are the elements of a culture of safety? Well, there are numerous components in an organization. First of all, it's very important that safety is established as an organizational priority. You would see this then in all employees sharing core values and goals related to patient safety. You'd see an emphasis on the importance of teamwork and collaboration, an emphasis on patient involvement in the healthcare setting as well as in decisions about their care. There's openness and transparency as well as individual and system accountability for safety. There's a non-punitive response to adverse events and errors. And by that we mean having a just culture, which I'll talk about a little bit later. And there's a strong emphasis on this being a continuous learning environment. So you have promotion of safety through education and training for all employees, from the board to all employees in an organization. The Agency for Healthcare Research and Quality in 2012 outlined additional components related to a culture of safety. They proposed that it's very important that we all individually, every healthcare clinician, acknowledge the high-risk nature of our work and that we each are committed to achieving consistently safe operations. They also concur how important it is to have a blame-free environment where individuals are able to report errors and near misses without fear of reprimand or punishment. That we decrease the hierarchy in healthcare settings and encourage collaboration across ranks and disciplines so that we're able to achieve positive solutions to patient safety problems. And that there's organizational commitment of resources to address safety concerns. That an example of that might be resources for nurses and pharmacists to sit down and look at and update drug libraries on IV pumps so that they're continually kept up to date instead of a one-time drug library being posted when a new IV pump is purchased. The Joint Commission has numerous education modules that are available, and these are available to anyone on the Joint Commission website that you would find extremely helpful in furthering your knowledge base on a culture of safety. And this link will direct you right into the Joint Commission website with some of these resources. The second domain related to safety is leadership. And one of the things that's been found to be absolutely essential for patient safety is that we work in high reliability organizations. This is where the commitment and the involvement of the top leadership in an organization come in. There needs to be direct involvement of top leadership who are committed to improving safety and the quality of care. That you would find mention of patient safety, employee safety, and the quality of care in the strategic plan of the organization, as well as in the strategic plan of nursing. There would be dedicated resources that are part of the annual budget related to improving quality and safety. There would be a learning environment where there are significant resources that are provided to every employee having at least annual education opportunities related to patient safety and evidence-based care. In a high reliability organization, you also have facilitated positive working environments, that it's part of the culture that everyone will work well together and that there will be high teamwork and strong communication and collaboration. And then finally, in a high reliability organization, you will find active engagement of staff in continuous quality improvement. The third domain in safety is risk identification and analysis. As I previously stated, that we're as much concerned with system effectiveness as we are our individual frontline care that we're safely administering to patients and families. And so when we talk about risk identification and analysis, we're looking at where across the healthcare system safety issues may arise. So we can break these down into 4 areas. First is latent failure. And these are failures that arise, sometimes called the blunt end, that arise as a result of decisions that people across the hierarchy of an organization may make related to the kind of equipment that's purchased, the policies and procedures that we have in an organization, as well as the allocation of resources. Lack of understanding about some of the factors that relate to frontline care that might guide, say, the purchase of equipment may result in safety latent failures from taking place. Active failures are what takes place at the interface of the clinician working in direct contact with a patient or family member. And this is sometimes referred to as the sharp end. This is where a medication error that might reach a patient, it's an active failure, but when we look at the risk identification and analysis, it may also be a latent failure. Then we also have organization system failure. And these kinds of errors or failures relate to either management or organizational culture, how we transfer knowledge and external factors. So an organizational system failure may be that we have a reporting system that is very clunky, or people are afraid to report errors for fear of retribution. And so this might be called an organizational system failure that prevents us from identifying what are some of the vulnerabilities in a healthcare setting. Then we have technical failures. These are indirect failures of facilities or external resources that maybe we weren't kept up to date on some alerts from a company, or they neglected to report complications that arose, and the company that produces either a piece of equipment or a medication hasn't notified the organization. So these are all components that go into this risk identification and analysis, which is the third domain of safety. One of the things that we look at when we talk about risk identification and analysis is having a just culture in an organization. And having a just culture means being able to look very precisely at various behaviors and identify where in an organization, how do we posit responsibility and accountability for healthcare risk and error. And so if you recall, we talked about system error as well as individual accountability. And the first piece of this is talking about normal error, which seems like an odd title for this, but this is the product of our current system design. It's understanding that there are various vulnerabilities in this complex healthcare delivery system that may make us vulnerable to making a mistake or making an error. And so when we do a root cause analysis, we're looking at what pieces in the system design may have influenced or had an influence on this error taking place. And it may be through some of the processes. It may be because we had inadequate procedures. Maybe training wasn't sufficient, or something about the environment or the design of care which made it an individual vulnerable to making a mistake. In this case, when we do the root cause analysis and we find that this was a system issue, then we need to fix the system so that these errors don't take place again. Occasionally, what we have in a just culture is what we call at-risk behavior. And nurses are very prone to at-risk behavior as a result of unintentional risk-taking. And this could be where we do workarounds or cut corners when we're trying to really do our very best, but have so many things to accomplish over the period of our workday that we have to prioritize. And so occasionally, we may find what we think is a quicker way to do something when it really can make the patient vulnerable to an error taking place. And so we need to be able to look at at-risk behavior when errors take place and question whether or not do we have adequate understanding of these at-risk behaviors. How can our supervisors or we with our peers act to remove incentives that would promote at-risk behaviors from taking place? And how do we build incentives for really healthy behavior, as well as increase situational awareness that if we choose not to do 2 independent double checks before we give a high alert medication, then we need to understand what the risk is when we have that kind of behavior. And that when an error takes place and we're doing a root cause analysis, we need to look at, was this actually negligence, or was it inadequate education or inadequate understanding of the risk? And then in about 5% of errors that take place, what we have is individual clinician, actual reckless behavior, intentional risk-taking. And these are the situations that really need to be managed through disciplinary action. So when we're looking at working within a just culture, we're understanding that the majority of errors that take place are a result of system failure, that sometimes it's a result of us taking individual at-risk or unintentional risk-taking. And then about 5% of the time, it's a result of intentional risk-taking, reckless behavior. In any organization, we have built into our care delivery systems various protections or checks in place. And occasionally, you can have all of the checks and balances fail. And we have what we call a Swiss cheese model. If you can imagine a block of Swiss cheese, you have holes in different places. Well, every once in a while, all the holes line up. And so the checks that we have to try to prevent an error from taking place fail, and then it reaches the patient. A quick example of the Swiss cheese model would be a medication error that a harried nurse practitioner or physician writes an order or checks an order in the electronic order system and inadvertently clicks the 30 milligram instead of the 15. Normally, this would get picked up in the pharmacy, but perhaps the pharmacist got distracted from a phone call from a nurse saying that they needed that stat med immediately. So that got passed. And then normally, the nurse who's ready to give this might realize that, wow, this is twice the dose that this patient usually gets. But maybe they're distracted or worried about some other patient that's calling to them. And so that gets missed. And so then this error takes place where the patient gets twice the dose that they would normally get. This is what we call the Swiss cheese model, where all the holes line up for an error to take place. The fourth of the 6 domains in safety are what are referred to as data management systems. It's very important that we have good reporting systems, good analysis systems, and then good feedback systems. In terms of reporting, we need user-friendly reporting mechanisms for errors and near misses. And by this, what we mean are that reporting systems are easy to complete and that clinicians feel very comfortable in filling out these reports. They don't worry about any retribution that might occur as a result of reporting an error. There also needs to be transparency in reporting and follow-up with a just and fair culture. And then there need to be periodic report cards to the staff regarding errors and near misses with follow-up to prevent recurrences. What some organizations have are in the nursing shared governance systems for a unit or all the critical care units, say, for example, that you would get a monthly or a quarterly report that in the clinical shared governance meeting, the staff would go over the report of what were the errors and near misses that occurred over that quarter or month. Why do we think they happened? And what do we need to do to prevent them from occurring again? This is what's called transparency in reporting and follow-up. When I've talked about having user-friendly reporting mechanisms, what has been found by many, many researchers is that it's very important that there be anonymous reporting system. In the January 2012, Medicare or CMS issued a report saying that they had reviewed thousands and thousands of healthcare records. And what they found were that 86% of errors with harm had not been reported. And what this speaks to is the absolute need for user-friendly systems and comfort with healthcare clinicians in reporting errors and near misses. The fifth of the 6 domains is mitigating risk through system thinking and design. There's a lot being published now on what we call CUSP, C-U-S-P, and this stands for Comprehensive Unit-Based Safety Programs. And what has been detailed in the literature are that there are 8 steps for how we make care safer by mitigating risk through efficient system thinking and design. The first step here is user-centered design. And these are approaches to make things visible so that we're able to see our actions at any particular point in time, or that there are forcing functions that make us do the right thing. The picture that you see in this slide is of a nurse who's wearing a vest while administering medications. And this is because we know that a common cause of medication error is interruption of the person who's giving medications. And so many organizations, the frontline staff have designed systems like this one of wearing a sash or a vest, which alerts other folks that the person who's wearing this is doing an action that is very important and for which they should not be interrupted. So this is an example of a user-centered design. The second piece here is avoiding reliance on memory. We think that we can remember everything that needs to be done in a particular shift, but the research on cognition has made us realize that we can't keep more than 4 to 6 things in our heads at any one point in time. So we need to have lots of things that help us simplify and decrease the demand on memory. And these would be standardizing and simplifying procedures so that they're always being done the same way, decreasing the demand on memory planning and problem solving. One way that's been demonstrated to be incredibly effective is using checklists. So when we open a tray to put in a central line, there would be a form there that would say, do this first, then this, then this, then this. So you don't always have to have that at the top of your head to remember how to do this particular procedure. It's also very important that organizations purchase equipment that's easy to use and to maintain. That would be an example of simplification. The third way to help make care safer is to attend to work safety. And we have a tremendous amount of research related to how many hours we work, what kind of workloads, staffing ratios, the effect of distractions on increasing hours, how all of these affect patient safety. And so we need to attend to the latest research. We know that working more than 12 hours on any one shift has a tremendous effect on worker and patient safety. And so we need to build in. It's unlikely that we're going to stop working 12-hour shifts in clinical settings. And so we need to build in breaks and understand the effects of fatigue. Things like huddles at the beginning and end of every shift. Having things like safe zones where people are not interrupted all help to promote worker safety. The fourth step in helping to make care safer is avoiding reliance on vigilance. We know that the use of well-designed alarms, rotating staff, and breaks decreases the need for remaining vigilant for long periods. The recent Ebola outbreak also helped us to understand how important it is to have a buddy on doing complex procedures like donning and doffing correctly, so that you have someone next to you who's able to call out, this is the step to do next, and this is the step to do after that, so that we don't have to rely on vigilance with the way that we're carrying out complex procedures. Effective communication, collaboration, and teamwork are some of the most important components of safe care. And this is where every person in healthcare needs to have training around teamwork, communication, and collaboration. And there are some wonderful programs that are available for effective interprofessional communication and collaboration that help us to understand and carry out transitions in care, handoffs and handovers. Team Steps is a well-known program for communication and collaboration, which is a free program that's available on ahrq.gov. Crucial Conversations is another very effective program. Though this program has a fee associated with its use. Another essential component for promoting safe care is involving patients and family members in their care. Patients and families should absolutely be in the center of the care process. And patient-centered care is another competency for which there is a program that's available. But it also is important in the safety competency so that patients and families, and we understand that knowing the plan of care Incorporating patients and family members in patient rounds and having patients and family members participate in care discussion is incredibly important in terms of safe patient care. The recently published book by Barnsteiner, Dish, and Walton on person and family-centered care has a vast compendium of resources to help promote safety that involves patients and family members in their care. The seventh step in promoting safe care is anticipating the unexpected. We know that reorganizing and putting in new processes of care result in new patterns. And when we're implementing major changes in organizations, we need to understand that there needs to be increased organizational resources that are put in place to help us through the transition period. So when we're putting in large-scale changes in the electronic health record, we need to have additional resources, super users, that are working each shift so that they're able to ensure that safety is maintained while we're going through these major changes. The Joint Commission has recently issued a Sentinel event alert saying that we need to have increased watchfulness while new tubing connection processes are being put into place for a lot of the equipment that we use around universal connections. That would help us anticipate the unexpected, have resources in place to help maintain safe, high-quality care. The last step in ensuring safe care is designing for recovery. Despite our very best efforts, it's unlikely that we will ever get to zero errors. Errors will occur despite the best of planning because healthcare clinicians are human and we're taking care of human beings. So we don't want to just recover from errors. We also want to learn from them. It's very important that we have very robust root cause analyses that take place and that we have processes in place for planning for recovery so that we learn from our healthcare errors. Has it ever happened before? Can this ever happen again? And what do we need to put into place to try to prevent an error from happening again? The last domain that we have in promoting safe care is the use of external drivers. There are many regulatory organizations that are putting systems and structures in place that mandate that healthcare organizations must put in place to promote safe care. The Joint Commission recently put their patient safety chapter online free to anyone in the world so that you're able to have what the requirements are from the Joint Commission that anyone can use, whether you are a Joint Commission accredited organization or not, to be able to use to see what you need to have in place to promote safe healthcare practice. There are many federal and state regulations in the United States. The Centers for Medicare and Medicaid have been tying Medicare reimbursement for hospitals to readmission rates and infection rates and quality outcomes. These are examples of external drivers that are really pushing organizations to put systems and structures in place to help promote safer care. Another component related to patient safety that is getting increasing attention is what is referred to as the second victim syndrome. Every healthcare professional who makes a mistake that results in patient harm feels terrible about it. And there are a whole collection of symptoms that may be exhibited that are sometimes described as post-traumatic stress. It's incredibly important that organizations have resources in place to help an individual understand the event that took place and to be able to stimulate healing and improvement in the healthcare system. When we recognize that there is something called second victim, then we are going to be approaching our colleagues who may have made an error that resulted in harm and provide them with support and encouragement. There's been documentation that up to 25% of healthcare professionals who make an error leave the profession. And this is extremely unfortunate because, as we know, most errors that take place are a result of errors in the system. And so we need to be able to provide support to our colleagues, and we need to have organizational supports that will give them the guidance and the help that they need so that they're able to recover from their feelings of inadequacy when errors do take place. There are many learning strategies that can be put in place to help us understand, become more proficient with this safety competency, and to be able to prevent errors and near misses from taking place in our direct care with patients and families. Most of these learning strategies have to do with simulation in safety breaches, in demonstrating how medication errors take place. Others have to do with being able to look at the latest research related to human factors and looking at things like staffing ratios, work hours, and having conversations about these with our colleagues so that we can better understand them. So we need to understand that we need to have these strategies put into place, not just to help students learn, but also to keep clinicians up to date on what are the latest state of the science, if you will, on vulnerabilities related to patient and provider error. Making progress on patient safety begins with how to learn about safety, keeping in mind that safe, effective delivery of care requires that everyone understand how complex healthcare delivery is, that there are limits to human factors and what we're able to do as individuals, that we understand what the safety design principles are, and these are integrated into our environments. What the characteristics are of high reliability organizations and how important it is that leadership at the top of the organization is involved, and that every healthcare clinician understand what so many of the patient safety resources are that are available to us easily, so to help us become more proficient clinicians. Keep in mind that 440,000 people die every year as a result of healthcare error, and that our patients are depending on us. So we have a responsibility to learn about how to give safe, effective care. Thank you.